So, Assalamu alaikum, everyone. Thank you so much for being here. So great to see a really nice audience. Um, so, without further ado, I will get on with it. So, I still consider myself very much a newcomer in this area of connective tissue disease associated ILD. But I'll talk to you more about it, and you can see my approaches to it. I have no disclosures. I hope that by the end of this talk, we can understand some definitions around it. We can recognize some concepts around the pathogenesis. We can appreciate frequencies and types of connective tissue associated ILD and understand some of the principles underlying the therapeutic approaches. And then I wanted to talk a little bit about the connective tissue disease ILD clinic that we set up, and Dr. Rafia, who just walked in, is part of. So just starting with a clinical context, connective tissue diseases, which we've heard in smattering throughout the earlier talks, are a group of systemic autoimmune disorders that are due to immune-activated inflammation targeting the connective tissue of your of the patient's body. And diffuse parenchymal lung diseases are characterized by widespread involvement of parenchyma, and there's varying degrees of inflammation and possibly fibrosis that can occur in this. So connective tissue disease-associated ILD is really a kind of cross-match of these two things. But it is worth mentioning at this stage that there's something called interstitial pneumonitis with autoimmune features, which may not show the typical serology of CTD but has something in clinical or morphological symptoms and features in the patients with existing interstitial lung disease. And we've heard a lot about it earlier today as well, but there's progressive fibrosis, which can occur in all sorts of interstitial lung disease, but is a very aggressive phenotype where you have a sudden and quick decline in your lung function, and an overall very poor prognosis. And CTD-ILD patients are also in that category. So this is just a quick look at some of the postulated underlying mechanisms, which can be extrapolated to almost all kinds of interstitial lung disease. But just thinking about what they are, some of them are things that you've heard before. We have genetic factors, gene mutations, but telomere length can not be maintained in some patients, and they have some mutations which cause them to develop lung fibrosis. We also have a huge body of evidence suggesting that microaspiration and gastroesophageal reflux disease can cause lung injury, cause epithelial cells to be more permeable. There's fibrotic hyperplasia, and then there's fibrosis as a result of that. Lung infections can be associated with fibrosis, particularly viral infections like EBV and retrovirus. Coronavirus, we've heard of that recently, as well as mycobacteria. And we know that tobacco exposure is recruiting inflammatory cells in the lungs, and there's an immune cell influx because of that. And aside from tobacco, other chemicals that are used as part of drugs can also cause inflammatory cells to be recruited, and sort of a dose-dependent toxicity, or an immune-mediated, I don't know if Dr. Sabia is still here, immune-mediated toxicity and allergic reactions within the lungs as well. And this is just a plug for pneumotox.com. I don't know if you've ever used that website before. It's really helpful because it lists all the different medications that can cause lung problems. And I've used it a lot over the years. On a molecular level, the injury to epithelial cells causes all sorts of mediators to be released from those cells. There's platelet activation, there's clotting, coagulation. The inflammatory cells that are present cause a migration and release of all sorts of mediators like the IL-1 beta, the TGF beta, IL-13 is very commonly measured. We've all heard of TNF. These all cause fibroblasts to migrate and proliferate and activate in the region that's been damaged. And then the extracellular matrix around there either experiences fibrosis or it starts to repair itself. And then there's overall contraction of the lungs because of all this tissue remodeling that's going on and resolution that occurs. So this is just a little bit about the pathophysiology. It's a lot of it is still under research, and this is really important from a treatment perspective because we're understanding better what kind of treatments can be utilized in what sort of pathophysiological phenomena. And when you consider connective tissue diseases, even more relevant because there are so many, first of all, so many different kinds of connective tissue diseases, and secondly, different kinds of interstitial lung disease that are commonly occurring with them. But before we come on to the types of ILD that these CTDs may have associated with them, I'm just curious to know which of these you think as an audience or as a doctor is most likely to be associated with an ILD. Anyone can answer, particularly the residents. RA, how many people think rheumatoid arthritis is the most frequently associated CTD with an ILD? Okay. So the most common one is actually systemic sclerosis, which has in earlier literature found to have at least 91% of systemic sclerosis patients had association with some kind of ILD. Inflammatory myositis, Dr. Ali Zubairi gave an excellent example, case study of that earlier. A lot of these diseases, these patients have ILD that they suffer from. Mixed connective tissue disease, 67%. So, by the way, it's in descending order, just to let you know. And rheumatoid arthritis, the numbers are something like 58 or 60% max. So it's not as common as it looks. Well, I think one of the challenges is that inflammatory myositis is a less common community connective tissue disease, whereas rheumatoid arthritis is a very common one. So when we see it, we're more likely to remember those patients. Sjogren's, we see some of these patients in our clinic. 27% of them have an ILD, and SLEs. 10 to 13% of these patients have an ILD associated as well. So just thinking about the clinical issues, the presentations, patients may be asymptomatic. Most frequently, they will have a dry cough that they've had for some time. They may present very acutely unwell with severe dyspnea. They may have experienced weight loss. When you examine them, they'll have crepitations, the famous Velcro crepitations. But I once did a little study and found that you can't really distinguish much on respiratory examination. So I kind of backed off on and relying too much on that, at least. But when you do some spirometry, you'll find they have restrictive lung function. You'll find they have an abnormal HRCT, and you'll be best friends with your radiologist to figure out what sort of ILD they have. And biopsies are not commonly performed in this group of patients. When you look at the guidelines, they've specifically omitted the mention of doing a biopsy. So I think that's worth remembering. The patients, once they are treated, may suffer from a lot of side effects from the drugs that they're being given. They may have a lot of acute exacerbations of their interstitial lung disease, or they may have some exacerbation of their connective tissue disease. They will develop pulmonary hypertension. They may get infections because they're on treatment or just because they're more susceptible to them, and they're immunocompromised. And this has a huge impact on their life. They can't work as they could before. They may become dependent on oxygen. They have costly treatments that they may or may not be able to afford, and they have a higher death rate because of that. So here we go again with some questions. What is the commonest type of interstitial lung disease that you would expect to see in these connective tissue disorders? So just to recap, we know that there's a UIP type pattern, which is an undifferentiated interstitial pneumonitis. And we know that there's a non-specific interstitial pneumonitis, the NSIP. And there are a few others which are less common. So let's say we have these two, UIP and NSIP. Rheumatoid arthritis, what type of ILD do you think you are more likely to see? What are the front row is not making any commitments this time. Okay, but everybody is right. UIP is the most common form of ILD in this patient group, but there are some patients who have NSIP, and some of them get an organizing pneumonia type picture as well. So this is worth remembering, because you don't know whether you're going to see the patient diagnosed with RA or just the patient with breathlessness. So you have to keep all these things in your mind. And when we look at systemic sclerosis, do you have an idea of what kind of interstitial lung disease we should expect? Yeah. So NSIP is much more common in systemic sclerosis. Inflammatory myositis. Yeah, NSIP again, 82% of these patients have NSIP. And mixed connective tissue disease, all I could find is that they have NSIP. There were not even like any percentages. Sjogren's syndrome, again, SLE, this NSIP in this group as well. And Sjogren's syndrome, 45% of these patients have NSIP, but there's also a spread of other kind of conditions, UIP, LIP, which is lymphocytic, and bronchiolitis in this group as well. So it's kind of useful to think of it that UIP is more common in rheumatoid arthritis, but you may have other conditions, and then the other different CTDs are more likely to have NSIP. So, as people mentioned, patients may be asymptomatic, and you may not like to think about giving them any medication. But I do think we should be holistic in our approach to therapy. We should tell these patients, especially our patients here at Indus, and in general, patients in Pakistan, we should educate them about their disorder. We should tell them that they're going to probably live with this disorder and complications of it for the rest of their life. We should tell them that they should, be careful in preventing poorly ventilated environments, and try and have a, clean lifestyle. Clean lifestyles including avoiding tobacco use. And we should encourage them, because they have a chronic disease, to be vaccinated for influenza and pneumococcus on a regular basis. So, even at a baseline, these are chronic lung disease patients who should be given this kind of intervention at the least. And then in symptomatic patients, you may like to think of some medication. And we've already covered a lot of this. For glucocorticoids are commonly used even in this particular subset of patients, and their impact is in weeks. I like to think of immunosuppressives as something that you're going to have to give to someone for months, and antifibrotics for really a beneficial action to be seen in years rather than in the span of weeks. Just coming back again to therapeutic approaches in general, symptomatic patients, all our team here knows that we very much push and encourage pulmonary rehabilitation in this group. It's really important. There's excellent evidence that if you use multidisciplinary techniques such as that, and especially in our CTD-ILD group, the patients do better. And there's a lot to do with empowerment, and enabling them to manage their disease at home, allowing them to improve their symptoms, and their walking distance definitely improves their overall outlook. You address things like nutrition, which is generally a big issue in our communities, but also in this patient group because of a lot of muscle loss. And because they're chronically sick, they're anxious and depressed. And if you approach them with a counselor who can help them cope with these mechanisms, then you're more likely to be doing them a favor than perhaps a lot of the drugs may do. And don't forget that you have to educate them as well, encourage them to live in clean environments, avoid tobacco, and take their vaccines regularly. And also don't forget that the dyspnea that they may be experiencing in your clinic could be because of complications of their interstitial lung disease. They may be developing pulmonary hypertension that you should be looking for. And because they have a connective tissue disease, more likely to have an anemia as well. So these are things I specifically look for. And just wanted to give you this kind of table, which has got a lot of information on it, but I find it quite heartening because of all the ILDs, the connective tissue diseases associated ILDs have a lot of literature base behind them. And this just summarizes some of the common ones. In rheumatoid arthritis, there's a lot of interest in anti-TNF inhibitors such as rituximab. We've talked about it, and it's been shown to stabilize lung function really well in the studies. And there's been use of antifibrotics. Inbuild was mentioned earlier. And that pirfenidone is not as evidence-based as nintedanib is. But interestingly, there's not as much convincing evidence for the conventional or the synthetic or the biologic DMARDs that we commonly use in rheumatoid arthritis. So it's easy because it's more accessible to prescribe methotrexate or, and methotrexate is a very good drug for rheumatoid arthritis, by the way. But in RA-ILD or in the case of mycophenolate, they're not as reliable compared to the rituximab in stabilizing lung function. When you move on to systemic sclerosis is where lots of research has been done. The cytotoxics have been beneficial. Cyclophosphamide in the SLS1 trial showed really good benefit. Mycophenolate was as good as cyclophosphamide, but it was better tolerated by that as well. And biologics such as tocilizumab have been used in this group as well. And 2 of the studies that have been done have shown that its excellent use has enabled them to become FDA approved. And nintedanib, again, has been shown to be a useful drug in the systemic sclerosis ILD group. More equivocal evidence for pirfenidone. So it's even though it's the only one we have, I'm generally very reluctant to offer it to the patient because they suffer a lot of side effects and then they complain they can't afford it and they already have to afford their CellCept. And so on balance, it's better not to give it because I'm not sure it's going to help them that much. Inflammatory myositis in general can be very responsive to treatment. You could just give them some steroids, and if you need to, you can give them any spare. They'll do very well. They have a good long-term prognosis unless they have anti-MDA5 associated ILD, which we mentioned earlier as well. And there's recently been some specific evidence for this group that especially like, what do you call it? Expert opinion, consensus building on what the recommended treatment is, and that was focusing on high-dose steroids, calcineurin antagonists, and perhaps cyclophosphamide as well. But this is a much rarer condition. We've heard earlier today it's really hard to even diagnose it in Pakistan, so this is really for academic interest in this stage. And there's been use of plasmapheresis in this group as well, and other such more far-out therapeutic approaches. So I'll just come on to our joint pulmonology rheumatology clinic. When I started this, I was inspired by a hospital where I worked in England, in Sheffield, at the Royal Hallamshire. They used to have this clinic once a month, and they only used to have 5 patients. And I think this is a perfect clinic because you only have 5 patients, and you're doing this really like big thing. And wow, I love it. I'm going to do this. I convinced my rheumatology colleague, oh, it's only 5 patients, Dr. Lubna, it'll be no problem. And I convinced my radiology colleague. I said, oh, Dr. Rafia, there's only 5 patients a month that we have to see. Now we have to figure out how we can fit these 5 patients in our slots. They're not 5. We often have up to 20 patients who are booked every month, and we're trying to see how we can manage that workload. But the idea is in this clinic that we would have patients who have a connective tissue associated ILD. We would do a multidisciplinary assessment before the clinic with the radiologist. So the rheumatologist, the pulmonologist, and radiologist sit together. We decide what the ILD is, and if there's some follow-up scan, we assess whether there's progression or not. And then we determine the clinical assessment later on that day. We give them therapeutic interventions. We collect all the data and do some analysis on it. So this started pre-COVID, and then obviously during COVID, everything fell apart, and then we've had quite a lot of staff changes and things. But nonetheless, have been able to keep this kind of idea in our mind where we do an autoimmune profile for diagnostics. And then if it's clinically indicated after that, we very much rely on Dr. Lubna's expertise as a rheumatologist to be able to look at that. She arranges a CBC, an ESR, SGBT regularly. I arrange a spirometry regularly. And then we do a HRCT usually on a yearly basis, unless we see that the FVC is falling and then, or they're having some more symptoms, and we do it more frequently. And if we can, we do it 2 yearly rather than 1 yearly. Once in 2 years is what I meant. And I also, we keep an eye on the echocardiogram on a yearly basis as well, so that we're not missing any pulmonary hypertension. So that's kind of our overall approach in this clinic. The first 100 or so patients that we had mostly had UIP pattern of disease. Some of them only had a rheumatological condition, but they may have had some obstructive airways disease. We decided to keep them in there. You see, it's much easier for the patient to come once to the hospital rather than twice to see 2 different doctors. So we decided to keep the patients coming there. NSIP, post-TB, fibrosis is so common, and bronchiectasis is common too. The most common rheumatological condition we saw was RA, and the association was between UIP and RA. So we're happy that it fits with the literature, but not the UIP SS group. But anyway, just to give you an idea of what their lung function was when they presented, most of them a little bit breathless with an MMRC of 2. Their FVC predicted is about 56%, which is just on the second last line. So, you know, there's a range from 44 to 72% amongst this early group that we saw. And we recorded their FVCs regularly. We can see, I mean, obviously this is not all the patient group, but some of it seems to be more stability in the FVC, but it's small numbers, and we have to kind of extrapolate a lot of that data, which is collected and needs to be looked at again. So that's just an idea of what's been going on. Thank you so much. I hope that's 10 minutes helpful to you all. Thank you.